Thank you very much, Fahad. I will start with some lightning about this new technology we have available in Saudi, and I'm sure even it's available in the Gulf states. TAVR, it's very common now in most of the center, and it's becoming like a angioplasty. And most of our fellows who are coming to the country now, they are very well trained in a structural heart disease, both like TAVI, mitral, and maybe the introduction of tricuspid. When we talk about actually, we had a chance to see two valve technology available in the area, the self-expandable and the balloon expandable, the live case. This is another self-expandable technology. It's Naviflex and it's Navitor. It's the technology they made some changes in comparison with the old generation, the Portico. This Navitor having more smart sealing, exceptional stability, and uncompromised access because of the large cells. This is a major difference between the Flex Nav, which is Navitor, which is available already in the country. When you can see the simultaneous unsheathing in the real time, you see more stability of the Flex Nav in comparison with the old Portico system. Very clear. Again, the Flex Nav, it's a very flexible delivery system, and it's low profile, 5 millimeter minimum vessel diameter can accept that. The smart sealing and the remarkable performance of NaviSeal, it's a cuff actively synchronized to the cardiac cycles, and most of the cuff will be inflated during the diastole to prevent the paravalvular leak. As you can see here, the active cuff inflates mainly during the diastole. This is a very nice demonstration showing the inflation of that cuff during the diastole. This is a 30-day outcome was presented in PCR 2021 by Lars Søndergaard from Denmark. Showed a 30-day outcome for the next generation, which is Navitor. As you can see here, they had like 120 cases and very good results in comparison with other valves. And the new pacemaker implantation here is 15%. And what they commented that they say 13 of their patients had already pre-existing conduction abnormalities. Now with the new technique we are doing with Medtronic, which is the most commonly valve used in our area, we are doing the cusp overlap for a while now, and we decrease the number of pacemaker by techniques, the new technique of cusp overlap. This is a hemodynamic and BVL result for this new technology. You see a very good valve hemodynamics up to 30 days. And the good news for this is the paravalvular leak. It's either none or very trace, and we noticed it in some of the cases we did. We did only 5 cases till now, and we are learning, and I think it's a good technology. The moderate to severe, it's a very small percentage maintained up to 30 days, and in EuroPCR now they presented the 1-year follow-up for those cases, and it's almost the same. Future patient consideration, the hemodynamic, as we mentioned, and we heard in the first lecture with the structural valve dysfunction, sometimes it's structural and sometimes it is non-structural. Here they are comparing the Evolute and Portico, and both of them, they are self-expandable, but in comparison with the balloon expandable, even this valve did a good result in comparison with the good performance in comparison with the Sapien balloon expandable. The future patient consideration and our consideration in the cath lab is how you engage those valves later in the future when the patient comes with acute coronary syndrome, for example. This valve has a very large cells, and this might make the accessibility to coronary angiogram is easier than others. The re-access study published in JACC showed a good percentage of crossing the cells in comparison with other technology in the market. This is how we suffer sometimes in the cath lab by accessing after TAVI. If you have a low frame intraannular like the Edward, it will be easier for you to engage either the left coronary or right coronary artery. If you have a high frame intraannular, again, it might be easier, and most of the difficulty you will have it with the high frame supraannular type of valves. This is a demonstration how you cross or engage or access the right coronary here, and you can see a very selective engagement, and even in the left coronary if you use this technology, because maybe of the large soles, it will be easier to cross such valve. This is a demonstration in one of the European Center for, this is always, or most of the time, you have to pre-dilate, prepare the valve nicely, and you go with the implantation. What we're going to show you here is one of our cases. This is a case done in our center. We did so far 5 cases by Navitor technology. 76 years old, male patient, as usual, diabetic. And what I like from the Gulf registry, our patient who were presented today by Dr. Shabi, 61% of our TAVI, they are diabetic. And I'm sure if you compare with the other people, you will not have this high percentage. That tell you, and not all of our patients will control. We are suffering from them. Diabetes, hypertensive, dyslipidemia. He had a bilateral osteoarthritis. He's in a wheelchair. He's overweight. Had a history of non-STEMI. He ended by with his ischemic heart disease in 2017. He underwent a CABG ×3, and he had also, before his CABG, he had a PDA closure. His aortic stenosis got worse year by year, and he had a multiple recurrent admission because of his pulmonary edema. His echocardiogram showed a heavily calcified aortic valve. EF was 40, his aortic area 0.7, and his gradient, the mean gradient was 36. It's a low flow gradient. STS score 5.2. The angiogram showed a patent lima to LAD and SVG to OM was patent. And we discussed them in the combined heart team meeting, and we decided for TAVI. We did this patient percutaneously, actually. And because of the CT measurement and the perimeter TAVI Navitor large size 29 was chosen, and pre-dilation, as I said, it's a must and recommended by the company. This is how the CT scan come from the company as a full report. And as Dr. Ahmed, who is the head of imaging, we do our assessment in the cath lab for the coronaries, and then we send the patient for, if we decided for TAVI, we go for CT scan, and the imaging assessment will be the one we depend on. But you know, it's good to have another opinion. But as I mentioned today, there is some few discrepancy between our measurements, especially for access, not for the annulus, the main concern, and the company people. This is the measurement. It was almost in this case equal. This is a recorded case. We done it with Proctoring from UK, and it was like I don't know about the sound, if you can make it longer.
Do you do two ProGlide or one and you see?
I think we discussed a lot of things.
Yeah, good question. Still currently 2 ProGlides, but increasingly we are going to 1 ProGlide and an Angioseal after.
Yeah, preferably 2, maybe.
I still prefer the first ProGlide to take well. That takes well, I feel happy. So we tend to reserve the Angioseals for when the ProGlide doesn't take as you would wish it to.
Yeah. What is the total? Make it more. 10? 10, please. 10 volley. You're okay there?
The balloon is ready. Okay, we will take a picture. Bismillah. Inject, please.
That's good view, huh?
I think that's a pretty reasonable coplanar view.
Yeah. That's good.
And
this is the same view? No. 14.9? Okay.
Yeah, that's your coplanar view.
When the confida is ready. Yeah, we are there. سبرك السفايد والله. But inshallah you're wrong. You can start pacing 120?
140.
140, okay, fine.
What, not 140 now? Spacing?
Go ahead. Very good. Deflate, it's okay,
Depace?
Yeah. Off pacing? Okay. That's fine. The port was open for the contrast, that's why it's there. Okay. In the dry goes. Ismail, where are you? Come here. Okay, now.
Actually, there was a lot of calcification in the right femoral bifurcation with the...
If you are familiar, you can do it.
It's in the iliac with the aorta. That's why you had some resistance, but it went okay after that.
So, you head there. We can push more, right? Go ahead. Yeah, go to the end. It's going easily. Very good. It's more flexible. Okay, go ahead. Yes, Dave, do you have any comment? You can say.
That appears to traverse the common iliac very nicely.
I can show you here. It's nice. I think we passed that.
You're past that. The fact your sheath is into the hub will tell you that you traversed into the distal aorta. So now,
absolutely, you're right. Go ahead.
Aorta.
Go ahead.
We didn't have much resistance this time.
Especially after the
so I think
whole sheet went in.
Hard time to
I think you clearly made the passage with the sheath, but the stool of the Navitor, I think, is probably the most deliverable system commercially available currently.
And you can see, I will make it non-mag. It is already non-mag, but we will see the descending aorta. Okay.
You've traversed that very smoothly and expertly.
Go ahead. Slowly now.
So crossing the valve, you might see drop in pressure.
We can go down a little bit. What do you think?
If you cross the valve a little bit more,
the
valve,
we are coming.
The valve frame is just above the pigtail.
That's it. That's perfect.
So now,
that's nice. That's nice. You agree?
I agree.
This is beautiful.
So you can start to unsheath the valve delivery catheter now, so it's overlapped.
The valve
you can see.
Okay.
This is more cusp overlap, not the coplanar we started. We are copying the same experience from electronic.
Yeah, so just unsheath so you get the valve frame and that delivery catheter distal ring overlapped, and then we can do a baseline aortogram to make sure we're happy with the starting position of the Navitor valve. So I think if you stop there, I think you've still got a little bit of parallax, so I think you probably need to take a little bit of the cranial off and leave the LAO angulation as it is.
That's better. That's
okay,
better.
So you've taken the parallax away in the coplanar view.
Absolutely.
I would do a baseline aortogram here to check that you're happy with the position of the distal valve frame.
Okay.
Yeah, I think no lower than that, but I think that's a very good starting position. And now you can start to gradually unsheath.
I'm doing it slowly and gently.
Yeah. I think the beauty with the Navitor, you can go as slow or as quick as you like. It's a stable system. That looks good.
Show me.
What I tend to do is when you start to get flare of the valve, then I would repeat my aortogram, and if you wish, move over to the
Otherwise, you can retrieve again. Okay, angiogram, inject. We don't want movement. Little bit down. What do you think?
Yeah, I think you can probably come back about 1 millimeter or 2 towards the aorta.
What do you think? That's better? Yeah, that's better now.
I like that.
Okay. Seems to be good. Continue.
Yeah.
We're going to reach 50% soon. Blood pressure is stable. This is one of the advantage of this type of valve.
I think
No
it moved a
compromise
little bit higher
of the
than what we
hemodynamic.
want.
I would go all the way now to the lock point so that you get anchorage on that left side.
لا تحرك لا تحرك أبوي لا تحرك. Don't move, please. I'm continuing.
Yeah, that's good.
Okay, you're going to hear the click soon.
So you will hear and feel the click of the lock point of
Yes,
the Navitor.
done. Yeah, it's there. Take a picture.
Yeah, I would do an aortogram in this view.
Inject, please. Seems to be
We've still got
What do you think?
Parallax. We've got a bit of parallax in the view. I think it looks good, but I think what we'll do is correct the parallax in this view. So I think, again, probably just come a shade more caudal, I think, and we'll make sure that we've got the parallax removed in the coplanar view.
Is this better?
I think doing more views, it's very good.
Less caudal?
Really about the deployment. Now it looks higher than what we want.
That looks reasonable, I think, to me. I can't
Can
clearly...
we take a picture? It's higher. It's high.
Yeah, so I think on the non-side, ironically, on the left it looks good, but on the non,
Right? Yeah.
you are at 0. You are level with the cusp.
Oh, yeah.
I don't think that would therefore give you a safe post-dilatation option if you needed it. So I think what would be sensible, stay in this view,
Okay.
do a partial resheath, and by turning the wheel obviously the other way, when the valve starts to collapse, you should be able to move it, I would say, probably about 2 to 3 millimeters into the left ventricular outflow tract, and I think that will then be an optimal position.
Excellent. And what I like from this, like the hemodynamics, blood pressure, everything stay the same.
We have little
And
problem.
the stability of the position, it's beautiful. It's very good.
I think for people, particularly if they have impaired left ventricular function,
Absolutely.
to give them a hemodynamically stable procedure is very advantageous. So see if you can push the device in
Slowly.
now.
It's the
Little bit
same
deeper.
movement you do with Medtronic. Nothing extra. Almost the same.
Yes, that looks...
And the pressure improved immediately by
Okay.
itself.
Pressure a little bit down now, but
Okay, we'll just continue now to unsheath the valve again. I think that position looks good. So let's re-expand the valve. Even if you have transient hypotension, because it's an intraannular valve, it normally resolves very quickly because the valve is functional so quickly.
flush. Show me. Flush. That's better.
That looks beautiful. So go all the way to the lock point of the valve if you're not already there.
I'm there.
You're there.
Beautiful.
Yeah.
So now, I would expect, I can't see
Pressure's
the
better.
hemodynamic, but I would suspect they're recovering.
Inject.
He is
Inject.
recovering.
He recovered already.
Beautiful.
It's okay. Okay.
So I think that is a beautiful position of the valve.
We can take the picture now.
This now allows for a safe post-dilatation should we need it.
Okay, we will see.
And I think that looks good. Your catheter is also central in the aorta, so it's not overlying the greater curvature
Right.
or the curvature.
Excellent.
So I think at this point you've got a nice stable catheter position, which means there shouldn't be a lot of tension stored within the catheter. Can you just show me where the wire is in the LV? Has it migrated to the apex?
That's nice.
What I would do, that looks quite nice. If I ever think there's tension on the LV wire, before I fully release the valve, I might just take the wire back just a small amount to take tension off it, like you've just done.
Done.
Perfect. Okay. So I like this position. What do you think about it?
Yeah, I think we are okay. I will do another injection, just double check 100%. I think it's reasonable, beautiful.
I think so too. I would be happy to deploy the valve.
What about the pigtail? Should we routinely pull it back at this stage, or we can keep it like other valves?
I routinely keep it where it is.
Okay.
And the reason I do that is to make sure I'm happy with the final position of the valve.
Sure.
I've never, and I don't use the word never regularly, I've never had a problem retrieving it. I just make sure I retrieve it by one insertion and not pulling the pigtail.
Okay, we can go, right?
So I think now at this point, what I tend to do, I tend to release the valve quite slowly.
Yeah, we push the button already, and I will go slowly to release the valve in the same view.
Full turns of the wheel until the valve is not capturable. So even at this point, the valve is recapturable and repositionable.
Keep 90%. Keep in this line, we can also recapture. We have a channel.
Yeah, but I'm open. Yeah, it's okay.
So what I would do is I would do this under acquisition just to make sure you're happy. So you're going there anyway. So just continue. If you switch to acquisition, now fully release. Beautiful. All the way to the end.
Okay, done.
Excellent. Well done. So you can see your valve did not move.
Perfect. We are happy.
That's the reason I leave the pigtail there, to give me that assurance that my valve has not moved.
And you can see the three, we see three. 1, 2 in the middle, and the third on the left side.
I think you can see 3. What I would routinely do is move over to a contralateral view, say straight REO.
I'm doing it actually while you are talking, and you can see them very nicely. 1, 2, 3. Yeah.
That also shows you the expansion of the valve in a different plane.
And the echo people, they are working now.
So I think that looks good. What you can do now is retrieve the nose cone of the Navitor system into the descending aorta. Your nose cone descends.
Just a second. Yes, I will.
That's it. So if you feed the wire in and retrieve the nose cone back into the ascending, then the descending aorta. Well done. Well done. Wire on. Beautiful.
This is the hand of the echo lady. Can you take your hand away?
And then in the descending aorta, if you relocate the nose cone into the delivery catheter for ultimate retrieval in due course.
Okay. Okay.
Your left hand stable, and right finger to your button and take right.
Done. Done. I did them all 2 hands. Yeah. Good. I think that's good. Now I need a wire to take the pigtail. We'll keep our wire.
I think there was no B valve, maybe trace or none in this case, and the gradient was excellent, 4 mean gradient.
Excellent.
I could live with that.
Thank you. Great case. Thank you very much. Excellent.
Pleasure.